Well, I'm here with Dr. Johnny Pearson Studdard. Johnny, hi. He'll be talking with us about Chapter 7 of the CMO's report. The chapter lead actually was Professor Chris Whitty, I think, but you're here in his stead because he's being busy with Brexit, I think, which is distracting everybody. It's an interesting chapter, Johnny, because it's a very important and topical thing that the NHS is struggling with, and that's multimorbidity. And if I'm right, I think 65% of people between 65 and 84 will have some multimorbidity. I mean, is that really a multimorbidity, or is it just that they'll take a couple of pills or something?
That's right. What's so important about multimorbidity and why it's so important part of this report that looks to health in 2040 is that it's an issue now. As you say, 65% of people who are 65 and over have at least two more chronic conditions, and that is expected to increase as we go to 2040. The two biggest drivers of multimorbidity are old age and relative poverty. And as we know, old age is increasing. We've got an aging population, and we forecast that to continue through to 2040. And so multimorbidity being an issue now and an issue in 2040 is quite clear.
Looking at the whole of the CMO's report, social inequality is a strong theme that runs right through it, isn't it? And certainly that's a strong theme of this chapter.
One of the key trends over the last 30 years is so life expectancy has increased for everybody. Healthy life expectancy has increased, but at a slowing rate compared to life expectancy. But that in Chapter 8, as it's demonstrated, over the last 16 years, 2000 to 2016, that inequalities in life expectancy have actually worsened. And so much so that in the poorest two deciles of women, they actually have seen their life expectancy reverse. When you look at the multimorbidity burden of disease within the country, that's much more heavy in those poorest communities. And with this worsening of socioeconomic inequalities, we can expect that means that the disease burden across the country will be clustered. So we'll have areas which have large areas of relative deprivation, more multimorbidity, bigger strains on the local health service, that means bigger strains on the social care service, but also implications for the wider economy. And so there's various different stages at which we must look at multimorbidity, both as an asset, both to the health service and to relieve that pressure, but also for the economy. One of the really interesting challenges with multimorbidity is that it is a relatively new concept. And so unlike individual diseases, we've got relatively little research on the matter, and so it's difficult to make evidence-based policy and evidence-based guidelines without that research.
And we have geriatricians who have had a rebirth, haven't they, really? I mean, there was a time when geriatricians really were not, well, they didn't occupy the position they do now in the medical hierarchy, but of course now everybody wants to hire geriatricians because that's where all the pressure is coming from. Are we to deduce from this chapter that the profession of geriatrician needs to develop further? I'm reading between the lines of this chapter. I'm starting to think, and I don't want to put this in an indelicate way, but I mean, geriatricians aren't good enough, and I don't mean that in an insulting professional way, but I mean there's a kind of game changer to be had with geriatrics.
That the nature of the patients driving the demand has totally changed, and geriatricians are one specialty who are used to having patients with more than one demand, but vast majority of other specialisms have become more and more specialist. So even your cardiologists, there are many fewer general cardiologists now, and they all have very specific specialties, which is great if this patient just has that one issue. But as we know, that's not the case. It's not going to be the case further into the future. So there's definitely throughout the chapter and throughout the report as a whole, a talk of we've gone from generalist to specialist over the past few decades, but the role of the generalist actually, and whether that's a generalist within certain specialties. So it doesn't mean that everyone does everything, but that within the medical field, for example, if you look at a lot of these, the clusters of multimorbidity, the different types of vascular disease is very common to cluster together. So whether that's renal disease, whether that's diabetic eye disease, heart disease, stroke. So actually you could see certainly the workforce coalescing around certain pathological clusters, which then manifest with similar clinical symptoms. And so move towards more of a generalist approach, both to the treatment and the prevention of patients.
And if you want to change work, you've got to change the people who do the work, haven't you? So does that sort of go all the way back to training? The approach is different.
Yes, I think there's definitely something in that.
We have single specialty clinics, don't we? Now you have a cardiac
Yes.
clinic and you have a diabetic clinic. And,
Absolutely.
So we're going to have multimorbidity clinics.
Well, absolutely, and similarly, even in the way that we're trained as doctors, specifically within the medical profession, we're very quickly put into a specific specialty, whether that's cardiology, respiratory, or whatever it might be. And then off you go, only ever getting more specialists. But from the clinical side, in terms of clinics, I think there's three ways that I look at multimorbidity. There's at the sort of pathology, there's at the symptoms, and then there's at the functional side and quality of life. If you look at the pathology, we need to learn a lot more about the aging process and how do these symptoms cluster. I've mentioned vascular diseases, but that allows for both treatment, early treatment, and prevention. But then at the symptom side, this is about how does this patient turn up and interact with the health services? What are their clusters of different conditions that come together regularly? And can we have clinics that, rather than just you go to 5 clinics a week for your different conditions, that's a regular cluster, we can get you to see the same physician once a week. But then the next step from that as well, which there hasn't been a huge amount of research yet in, is how does multimorbidity affect your functionality and your morbidity? So rather than just producing these guidelines around your risk of dying according to different conditions, it's important to know how functional you are and how can we structure your approach through multimorbidity based approaches to ensure that your quality of life and your functionality, getting you out of hospital, living independently, is maintained as long as possible.
I'm just thinking about what you said when we first started this conversation about social deprivation and those impactors there, because in theory we're getting older now. I mean, my generation, I haven't gone through a war, I don't have a legacy of an industrial past, I've never smoked, I've lived a reasonably comfortable middle class life. Even comparing my life to my parents' life, and certainly their parents to their parents' lives, is changing. We should be living longer, and we should be healthier. And although we push the final day, the Grim Reaper day, further down the line, we should be living healthier. But it's the social determinants of health, isn't it? And really, I think that comes through in the chapter. And I'm not sure I feel there's a conclusion there about what we do about it.
You're right. I think the two things are there that what Chris Whitty and Alex say in the chapter, Alex Lee, quite clearly is that a lot of this requires more research, but applied research, so that we can put it into practice. But to do that research, we need to go where multimorbidity is common, and it's most common in the poorest areas. And so to be most effective, this research needs to be done in an applied place that can be implemented quickly. But on the social determinant side, you're absolutely right that as our life expectancy has increased, the morbidity gap between when you become less than healthy, living life in less than full health, through to the age that you die, has got bigger and bigger. And a lot of that is down to lifestyle disease or behavioural risk factor stuff, which I know Teresa Marteau will talk to from chapter 8. But we've been very good at treating disease and managing diseases. So you can live with chronic diseases for an awfully long time. Haven't been awfully good at cures, actually. A few decades ago we were very good at cures for infectious diseases, and then not so good at prevention either, because if you can prevent someone becoming diabetic, then that's fine, they'll live in good health. And if you can treat effectively someone's diabetes, then again they'll live in good health. Whereas at the moment we manage these chronic diseases, which means patients live for a long time with many diseases. It's a cost to their own health, cost to their own family, but also of course there's an economic cost to society.
Huge cost to the nation. It's a really interesting thing to talk about, and I just forecast for me. Just where would you hope that we would be in say 20 years time?
So I think in 20 years time, there's real hope that we can understand what the drivers, having understood what the drivers are of the common clusters of multimorbidity, and got specific and effective prevention measures.
We kind of know that now, don't we?
Well, we've done very well within the social determinants of health, for example, at defining the problem.
Well, we know it's poverty,
exactly.
It's diet,
or
it's
education,
depression, stress, work.
Absolutely.
Yeah.
And we've been very good at defining that problem. What we need to do now is to define and implement some solutions that are feasible, that are practical, and that work. And that's the key. In the next 5-10 years, if we can identify and embed those, then we can really look to a much brighter future.
And that's the 3 pillars of public health.
It is.
A job, someone to love,
Yeah.
and a safe place to live.
Absolutely.
Well, if you can fix that, I guess we cracked it. Johnny, thank you.
Thank you.